Good afternoon. This presentation is about cataract and zonules. I don't have any financial interest. As we all know, have to assess the zonules before doing our cataract surgery. Zonules could be normal, all the zonules are intact 360 degrees, or there is mild weakness or moderate weakness or severe weakness of the zonules or loss of part of them. Preoperative assessment simply by history taking if there is a history of trauma or collagen diseases or congenital anomalies, pseudoexfoliation, and glaucoma. All these are predisposing factors for zonal adhesions. Simply as you see on the right-handed picture, there's here the pseudoexfoliation, and this is very common to be seen in our region. Or the tremulousness of the iris, which is simply see that the iris is moving right and left as if there is a tremulousness in it or moving on it. It's a sign of lens dislocation and zonules. Congenitally, we may have a Marfan Syndrome. Just to stress in that the Marfan Syndrome or the lens is deviated up and to the out, the zonules are stretched. The zonules are present, they are not absent, but they are stretched all around or all over the area of weak zonules. Or sometimes the lens could be subluxation due to trauma. Take care during the capsular access. The staining of the capsular access is mandatory in the mature cases and in the traumatic cases, because here it gives you more tough anterior capsule that you can control all around. Use oral weapons in capsular access, enough of these viscoelastic, and control the capsular size because you may need to put a capsular tension ring inside and allow the visualization of the anterior capsule to the end of the surgery. This staining, try to use the capsular forceps or the microincisional capsular forceps. So the weapons, the microincisional capsular access forceps is a very good weapon that can control the capsular access even in the subluxated lenses more than 270 degrees of zonal adhesions. It gives more control, more accessibility, and more fine movement. Capsular tension rings should be present, whether there's a regular Siona ring, the Ahmed segment, or other different types of rings. And the use of the capsular tension ring is now getting higher and higher in many patients, especially cases like high myopia. When we put the premium IOLs for them, implantation of the capsular tension ring is very simple, that you can insert the ring simply through the main wound, guided by the spatula in the other hand, and guiding the capsular tension to be inside the bag, rotating the ring in the bag till it could be inserted and completely inside the bag. Then, under enough of these and viscoelastic, insert your intraocular lens simply. As you see here, in this case, we inserted the ring just to know that this patient has high myopia. It was a +11, and we inserted one of the premium IOLs for it. And so we found that the insertion of capsular tension rings in these patients, it gives a more predictive refraction as it gives more effective lens position prediction. Anterior chamber maintainer is another important tool to have stable anterior chamber. The vitrectomy machine should be beside you. I don't have any financial interest of these machines. And different modalities of intraocular lenses, whether the 3 pieces are as the very size or the even the anterior chamber regular as with the open canal. Subluxated lenses, and this is an old case where the lens is subluxated, so use your second hand as a way to support the subluxated lens with the spatula, and after finishing the capsular access, preferable to put the capsular tension ring. These old rings were already inserted in an injector, and just simple injection of the capsular tension ring in the bag. It allows the presence of the capsule tension ring inside the bag, behind the nucleus and away from it, and thus it gives stabilization and allows phacoemulsification easier in these cases. But in spite of that, some areas could be dehiscent and vitrectomy is needed in these cases. After implantation of the 3 pieces IOL, don't forget that these capsular tension ring, these rings give you support that you can even put your IOL over the rings with the defect in the posterior capsule, and this is one of the advantages of these rings, but sometimes it may need suturing to centralize the IOL. In this case, we did not suture, and I'm showing this video to just give a message that if you don't put the suture, still the lens will be a little bit displaced. So preferable to put the sutures to fix the IOL in place, in spite of having good results at the end, but preferable to put the suture in order not to have astigmatism. Sometimes you have induced capsular zonal dehiscence in cases like this. As you see, trying to get the capsule in a very simple case to hold it or to create the anterior capsular rexus is difficult, as you see, as it's you cannot find the edge. So I created another edge, and still I don't know what's the cause, but simply because there is some zonal dehiscence in this area. And after getting the edge of the capsule with the capsular rexus forceps, and after giving enough of these, this will help in creating capsule. But see at the end of the capsule how it moves outside and how we could create zonular dehiscence. And this was a young patient, and as you see here, the capsular rexus was normal in the lower half and upper half, but at the end of the rexus, see how it moves outward, and even the zonules were markedly stretched. And here there's the little sign as it goes out. You have to put the capsular rexus in, and pulling in the rexus. Be sure that it will come, but be careful that it may stretch the zonules. As you see here, the zonules are so much stretched, so be careful not to cut the zonules of this area. But some of the zonules will hold, so be careful of the zonular dehiscence. And this is another case of last minute complication. While on insertion of the IOL, nothing, everything was normal, but suddenly you find that the IOL moved in its place, and you didn't do anything wrong, except maybe the patient had some stain at the time. So simply don't forget to put your capsular tension ring. It will solve the problem as long as there is no vitreous surgery. Must mind widening of the main wound, and insertion of the capsular tension ring inside the bag around the lens will stabilize everything and return the situation in its original position. This patient also had intravitreal injection during the surgery, as was a diabetic patient. Iatrogenic zonular dehiscence. This patient, after insertion of the IOL, straightforward, and the IOL is in the bag. It's at the last seconds of the surgery. Nothing but part of the haptic is outside. The patient started to move vigorously. He was coughing. The anesthesiologist asked me to wait, but I didn't wait and see what happened while insertion, trying just to put the haptic inside, and I got whole part of the capsule, the upper part. Simply here, putting the capsular tension ring solves the problem and will turn the situation in its position. Put the capsular tension ring away from the area of zonal dehiscence, and see while it moves, it stretches the capsule back, and the situation becomes normal again, and with good visual results. Again, these are long zonules. While you are doing the capsular rexus, sometimes here the zonules are inserted much more anterior than expected. So be careful while you are doing the capsular rexus that you may take part of the zonules with you. And this is what we call the long anterior zonules. So be careful not to, as you see here, the zonules are cut while you are doing the capsular rexus. Be careful not to extend to the outside. The Argentina flag syndrome is known to all of us, but sometimes even double Argentina flag may occur with 2 incisions, and even you are out, nothing, and under the pressure, more and more Argentina flag syndrome. So be careful that you have to cut your rexus with the scissors, and be careful during the phacoemulsification. Cases of aniridia, where there is no support at all, there is no zonule. Here you can put your Yamani technique for putting your IOL, and this is about 11 years old girl, and after putting the Yamani, it was in place. We did not put an iris shield here because the child was adapted to this situation for fear of increase of intraocular pressure after that. The Fixoflex is a new ring that we are inserted, that it's put inside the injector and simply put the Fixoflex inside the bag. And after putting this ring in the bag, we can put our IOL. It has two edges that can support the IOL. It will be of a great value in cases of toric IOLs and the premium IOLs. Assess the lens. Be sure that this subluxated lens before doing your surgery, does it move or not? Yes, it moves. So simply by these Q-tips, you can put the lens in its place and you can hold it in its place and get it with the intracapsular technique and then putting your various eyes at the end after closure of the iris because it was a traumatic case and then implanting your IOL. So the take-home message is assess the zonular status, be ready with all your weapons. Plans A, B, and C should be ready. Adopt a new strategy proper to the situation. Give enough time, and more time for the patient to have the best results. Thank you so much.